Wonderful.
Good. Nice. All right. Thank you for having me, Megan and Corey. I'm a longtime member of the Harm Reduction Nurses Association and happy to share this guest lecture. I'm joining you from Fredericton, which is the unceded, unsurrendered land of the Mi'kmaq, Passamaquoddy, and Wolastoqey peoples. And a lot of my work took place in Nova Scotia. I've just recently moved to New Brunswick, and that's all Mi'kmaq territory. All right, so just to situate this in terms of my work, so part of the discussion in this seminar is about work that comes from Wellness Within, which is a volunteer nonprofit organization in Nova Scotia that formed in 2012 with the express purpose of providing doula support to people who are incarcerated in the provincial jail, the federal prison, and the youth detention facility in Nova Scotia. So a lot of what we've learned through that dedicated service is communicated in this seminar. My clinical work, here's a picture of my team. For years, I was at the Nova Scotia Women's Choice Clinic. We've been working for several years to change it to the more appropriate Nova Scotia Abortion Clinic. And I also have practiced for years at the IWK Health Center in postpartum care. So this is both work from a clinical perspective and from a community-based advocacy perspective, and where those two intersect in terms of our nursing obligations, our duty to practice as advocates. I already did that. When I do a land acknowledgement, I think it's important to situate that in terms of our responsibilities as nurses to participate in reconciliation in the ways we were called to do so through, for instance, the TRC and the Murdered and Missing Indigenous Women report of 2019. So these are just some of the calls, the TRC calls, that are our responsibility to do something about. Yeah, so we bring these into our actions as taking our land acknowledgement into practice. So harm reduction and reproductive justice are very strongly enmeshed from a theoretical and a philosophical perspective. Criminalization as a process increases the risk of exposures to system harms. So not just prison's the most obvious, but also the child protection system and psychiatric institutionalization. And those sites of carceral harm all have reproductive oppression outcomes, forces. And reproductive justice as a term, as a theory, as a movement developed by Black American feminists, coined in 1994, really is shaped around the concepts of the right not only to not have children, so the right to abortion and contraception, but the right to have children and to have those children in safe and sustainable environments and spaces, free from violence from state actors such as the police. So as reproductive justice workers, it is my position that that work is inherently abolitionist. And that's the point of my book, that many of us come into this work from an interest in abortion and a commitment to abortion, and need to recognize that reproductive autonomy is far beyond the right to abortion and must take us to a place of eradication and abolishment of carceral institutions in our society, because they present inherent barriers to reproductive care. They destroy connection to family and community. They restrict your fertility. And of course, people who are in prison are routinely subjected to sexual violence. So these are all violations of the principles of reproductive justice. Now my screen, oh, good. So these are some pieces of legislation that I encourage everyone to become familiar with. These are, well, I mean, the Nova Scotia Corrections Act is the provincial act in Nova Scotia, but there are, you know, equivalent provincial statutes in all of the other provinces and territories that govern how corrections is run. The Corrections and Conditional Release Act, which has a whole section that covers the prisoner's right to health care as it is delivered at professional standards, right? Commissioner's directives, these are regulations within the federal prison system. For instance, 800, which governs healthcare provision. 566.6 covers escorts, including medical escorts. 768 covers the mother-child program. I'll talk a little more about that. And then beyond what we have provincially and federally, we have international commitments. The UN Convention on the Rights of the child's right to be parented, and the child's right not to be punished for actions of their parent. The UN Bangkok rules, which provide the minimum standards for how women prisoners, people who are incarcerated in prisons designated for women, should be treated. And the Mandela rules, which govern the treatment of all prisoners and have many stipulations pertaining to health service provision, including the care that pregnant people deserve, and also our obligations, our duties as healthcare providers to treat people in prison as we would any patient. And that means upholding their rights to privacy, confidentiality, and so forth. So that's the homework. Know those things, learn those things. Having some stickiness trying to advance the slides. I don't know what that's all about. Okay, so before we even talk about the maternity, perinatal, reproductive context, it's important to recognize that people who are incarcerated are unwell. That's the starting position. They go into prison unwell, and then they get more unwell in prison. Almost everyone has a childhood history of sexual and physical abuse. Most have a diagnosis, and that's the diagnosis, not just the symptoms of mental illness. Most are on psychotropic meds. Most use substances, and an increasing number, it's not super relevant for pregnancy, but it's certainly relevant to the health profile of people in prison. Over a quarter of people are over the age of 50. And I think we don't think about things like, how does arthritis interact with getting up on a second, like on a bunk, right? Where are the wheelchairs in all, you know, I'm sure you can picture in your minds the movies, the staircases going up to the cell blocks. Where do the wheelchairs fit in, right? Just these basics. There's an incompatibility between healthcare and incarceration. And yet there's a persistent myth that healthcare is available in prison, that you should go to prison to finally get access to healthcare. A lot of this myth is developed in the US where because of barriers to health insurance, this actually can come true in some settings, that you would be denied care until you were institutionalized. But the reality is that prison is really, really unhealthy. Increases the risk of self-harm, suicide, vastly increases your risk of homicide and just death. You are more likely to die if you are incarcerated. Rampant infectious disease, a lot of stuff with body image and eating health. Yeah, it's not like in Orange is the New Black where there's this big, huge field and chickens and walking around all the time. That's not what it's like at all. the jail where I do most of my work. The yard is a concrete pad with chain link fence over the top and 4 concrete walls around. In terms of access to healthcare, you're not only facing the long waits that all of us are facing, you've also got these bureaucratic barriers. You have to make your requests for healthcare through guards. And so those guards are triaging you, guards who are not healthcare providers trained to triage. Yeah, just a lot of barriers to info, barriers to support. And then of course the carceral actions, the mental health and physical violence of strip searching, of restraints, of isolation, and so forth. In prisons designated for women, this is the language that I use. It's very problematic to try to talk about the stats when we don't have any stats about trans and non-binary prisoners. So this is the best we do, the people who are in prisons designated for women. So you'll hear me say that a lot. So fastest growing population in Canada and frankly globally. But even though people in prisons for women are growing so rapidly, that population is still a small portion of who is incarcerated, and so is very invisible to the system. You have locations that are very few and far between, and what that means is you don't get to see your people. Nobody's coming to visit you because there's 10 times fewer places to visit. Yeah, and also so many families who experience marginalization are run by women. So if the mom is incarcerated, then nobody is taking those kids to visit. Whereas the reverse, with incarcerated men, often will have a female partner who is supporting getting the kids to visitation. Most people in our system are in the provincial system. The provincial system is for people who are remanded, so they're held before trial. So they're not, you did the crime, you did the time, not at all. These are innocent people waiting for trial, innocent until proven guilty. 80% of people in provincial jail are on remand. Then you could have a sentence of up to 2 years less a day. 2 years and beyond is within the federal system. Again, I'm facing this sticky slide. I don't know what trick makes it go. There. I feel like most people have heard by now just how incredibly vile the colonial racism in the prison system is in Canada. Over 50% of the people who are in prisons for women are Indigenous. And so we see the prison system as a state translation, a contemporary translation of the residential school regime, the 60s scoop, the ongoing millennial scoop. It is where women are disappeared, where they go missing from their families into these locations. And many of the people who are in prison now are survivors of all these colonial reproductive oppressive movements, including people who have survived forced sterilization. The other thing to keep in mind from a reproductive health perspective is that Indigenous people are disproportionately young. So they are more likely to be incarcerated in their reproductive age years and miss out on that opportunity to build their family because they're incarcerated. They're also more likely to be classed at a higher security level. Security classification is, it's been decried many times as a systematically racist process. And what happens if you're classed at a higher security level, and so for instance, you'll be classed at a higher security level for your health needs. If you have experienced trauma in your past, that makes you riskier. And when you are classed at a higher security level, you're denied access to programming. Not that there's a ton of programming anymore anyway since COVID, but yeah. So we have very little research about the reproductive health of people in prisons. This is my favorite paper, Jessica Liauw, collaborator, who's a maternal fetal medicine specialist at UBC. So in this study, survey in Ontario of people in a jail for women, here are your stats, right? So most have been pregnant, high parity, actually. Very high rates of unplanned pregnancy, abortion rates about double what we see in Canada generally. And, DOP, that's DEPO. You know, the most common forms of contraception that people are using are not the most effective kinds, but they're the cheapest, right? Yeah. So when you think about the access to these care services that people have when they're incarcerated, we also need to keep in mind that remand factor. So if most of the people are waiting for trial, if the average length of stay in a provincial facility is only 1 week, 1 week is enough time to disrupt your contraception use, to get you cut off from what you were using. And it's also not enough time to get you started on something that would be useful for you. So we have a really, again, that myth that prison is a great time to get healthcare. No, it isn't, right? This is some of my research looking at the mother-child program, which in theory is available across the federal system. So there are 6 federal prisons for women across the country. And in theory, all of them are governed by Commissioner's Directive 768. All of them have space for a mother-child program where babies or little kiddos who are under the age of 5 can live with their mother full-time. And in theory, you don't have to be born while your mother's incarcerated. You just have to be under the age of 5 and meet these very strict eligibility criteria. The biggest one being the security classification. So you have to be minimum or medium security classification. So there has to have been enough time for you to go through that process. And like I said, Indigenous women are more likely to be classed at a higher level because of their past, not because of their crimes construct. So shocker, my research found that people who do get to participate in this program are disproportionately non-Indigenous. Very few, you know, over 120 years, people participating in this system, when every single day there's 700 women in this system, most of whom are moms. So as a result of this very low participation, I mean, most moms are separated from their kids, most kids are separated from their moms, but also you have the system that creates a hierarchy, an inequity within a really inequitable system. So they're the have-nots and the haves within this, the moms who get to participate, the very few and far between, versus the people who don't get to participate. And the last thing I'll note on this, that one of the criteria is that you have an alternate caregiver in the community. So think of all the women who are coming from up north, coming from rural reserves, First Nations communities, and they don't have somebody 20 minutes down the road from the prison who can come and pick up their kid in an emergency, and that's a requirement. The other requirement is that you have to have a babysitter within the program, within the prison. So what happens if your babysitter, and she has to go through all the rigmarole too to get approved, what happens if something happens with her? Say she gets in a fight, somebody hurts her, she's put in SEG, she's not available, and you lose access to your kid, and your kid's booted out of the program. Incredible precarity to participate in this. Think about the emotional and mental stress of that precarity. Children of incarcerated parents in Canada are not counted. And that means exactly what it sounds like. People who aren't counted don't count for policy. What we do know from the international research is that they experience vastly higher rates of both physical and mental illness and die earlier than children who do not have incarcerated parents. Incarceration of a parent is one of the original ACEs from the Follette study of 1998, adverse child events. We know this to be very true. We've known it for decades and decades how bad this is. We do have some Canadian research that a mother ever having been incarcerated will be at increased risk of small for gestational age, of preterm delivery, which is the #1 cause of death of newborns in Canada, and of low birth weight. Okay, so having painted that picture, how do we as nurses, as harm reduction nurses, how do we minimize harm? So in an abortion care world, let's start with thinking about what are we going to support somebody to have? Is medication abortion, only available in Canada since 2017, but very increasing normalized and used every day? It's more normalized and used. But is medication abortion a realistic option for somebody who's in a cell? People don't have access to sanitary products at the best of times. How are they going to handle literal bleeding? That's the purpose of it, right? To bleed. And where's the pain relief? Home abortion is a wonderful option if you have a hot water bottle and some cannabis and a friend and Netflix. It's really very difficult to imagine going through it in a carceral environment. So if somebody's going to have an aspiration procedure, well, then now you've introduced the presence of guards. How are you as staff in that clinic going to negotiate getting those guards out of there, right? How are you going to do that? And it's something to practice it. What words are you going to use? Who's going to back you up so that you can say, this is not okay. We won't be able to do this. Most clinics in Canada do not allow anyone in the procedure room. Guards aren't different, right? If we don't allow the mom of the 13-year-old girl, then we don't allow guards. So how are we going to get them out? Think about it, practice it, talk about it with the team so you're all together on that. Obviously, remove restraints. It's barbaric to treat someone who's handcuffed or shackled. So you're going to do it. Practice how you're going to talk about it. Make sure everybody knows that that's how you practice care ethically. Nobody can consent to care. And in abortion care, we're so concerned about coercion. No one can consent to care if they're literally bound. Then for the last bit here on this slide, for our post-abortion contraception, what can we offer that is the most bang for the buck? Can we get somebody, usually things are covered when people are incarcerated. So that's, or if people are on social assistance, things will be covered. So can we get somebody an implant, an IUD, something that will last them for a while so that they don't have to go through this kind of thing again? Because every time you leave the facility for a medical appointment, you're strip searched. And every time you come back in, you're strip searched. So we as nurses need to know this. For somebody to come to us, they've already been sexually violated to get in and out of the building. Our care has already caused that to happen to that person. So we got to minimize those care moments because they're actually really brutal. Okay. Prenatally. So if somebody's keeping the pregnancy and is going to experience a lot of prenatal care while inside, and there is a mother-child program. So for all the federal sites, there is one. There's also a mother-child program at Alouette in BC, the provincial jail. You have to apply well in advance. You have to apply like the instant, and you have to push to get somebody's application to be recognized. So as nurses, hopefully we will get to see these patients early on. We can advocate for them to get the standard of care to be coming in for those appointments that we know that they need, for screenings, that they're offered everything. So on the one hand, yeah, somebody has to be strip searched to come see you. But on the other hand, You never want someone to be denied care because it's inconvenient for guards to bring them in, because the staffing's low at the jail, so they don't have the 2 escorts they need, right? You need to push against that because people obviously need the care, right? And beyond what you can advocate within your care domain, there's the advocacy for what's happening for this person. It's against the Mandela rules for that person to ever experience segregation. They shouldn't be. And that means the lived reality of segregation, not segregation, right? If somebody's all alone, they're all alone. They need more calories, they need exercise. These kind of things are basic to help deal with the increased risk for all of those complications, diabetes, gestational hypertension. Those are going to be higher in a population that's experiencing already so much chronicity. Most of these patients will likely be on an agonist, and as they get more pregnant and get bigger, they're going to need more. So you're going to see methadone, Suboxone doses increase as the pregnancy goes along, not decrease. They'll decrease, after postpartum at some point, and that's normal. You want to see that, and you should be advocating for that to happen. And it's all about planning. Labor and birth, foresee it, it's coming. Things happen way faster than we think. So for the labor and birth, as we're planning this, who's going to be there? Is there a doula? Is there a family friend? Is the family friend allowed to be there? We have COVID era policies that are really restrictive against visitation. And I don't mean the hospital policies, but whatever policy is in place at the prison will translate into the hospital space as well. So somebody might think their mom's going to get to visit, but they're not, because they weren't allowed to visit at the prison. So that needs to be broached. A lot of this stuff is you don't want to broach it because it's so sad and kind of enraging, but you have to broach it because it's way worse to discover at the last minute that no, your assumption that that person could come, absolutely not. A lot of people, their partners, boyfriend, girlfriend, spouse also have experienced criminalization. They have a record and they won't be allowed to visit. So look into that early and find someone who can. The alternative is not no one who can be there, right? Again, this use of restraints, always, how are we going to navigate this? If someone has their hands bound, if someone has their feet bound, it is an enormous falls risk. And so we all are doing these daily falls risk assessments, right, in the hospital. This is not on our falls risk, but this is key. You can't be having somebody in restraints, it's falls risk. So use that tool, use that as a reason to get some humanity into the care, right? Eyes and ears is a policy that the guards have to have sight and sound on the patient. And if it's medical procedure, and frankly, everything nurses are doing is a clinical procedure, is it not? Then that can be eyes only. And of course, it can be eyes on a person's head, not their vagina. But you got to negotiate that. So anticipate it. How are you going to work through that, right? We've used like a Zoom with no sound kind of thing. It's, yeah, it's hard. And is everybody aware of what's happening? Because every time there's a change of shift, you have new people who very likely could be afraid of this patient. So it's communicating not only how all these arrangements, but also the love and compassion. That needs to travel through a change of shift. It's a vulnerable time. Postpartum, because most of the patients are on OAT, most of them have a postpartum stay while the baby is withdrawing. So if we're talking not 24 hours, we're talking, 2 weeks, 2 months. So is the prison aware of that? Are they anticipating that? Are they definitely going to allow that to happen? They should. That's a clinical recommendation. Who's the point person? They're going to need a lot of stuff if they're spending 2 months in the hospital. They're going to need, you know, a radio and underwear and toothpaste. Who's going to get them all their stuff? Then there's the breastfeeding considerations, right? Who's paying for supplies? The hospital will provide them, but what's the plan after that? If we're going to get somebody started on a pumping schedule and they're really comfortable with that, how's that going to continue? Plan, right? How is communication going to happen? Can the patient be receiving phone calls? Can they receive visitors? Why not? So trying to figure out what are the ways we can maximize the support. Can the person go outside? Are they going to spend 2 months indoors? Can they have a smoke? Are they not allowed? Think about all these things. Okay, so newborn withdrawal. You know, somebody can do a whole hour on that, a whole week on this, but we know that this is increasingly prevalent generally, and it's certainly very frequent among the people who are experiencing prison. And it's very challenging for the mom, the parent, because this, you know, it's a multi-system irritation. These babies are cranky. And these moms are inside 24/7, and they don't have any of the pleasures that we can turn to, right? They don't have that relief, and it can be really too much. So is there a relief plan, right? To treat newborn withdrawal, the gold standard is for that baby to be with the mom, skin to skin, breastfeeding, right? We want to see that that baby can eat, can sleep, can be consoled. That's how we know that that baby's doing well. And that means a really chill space and a mom who is as chill as possible. How is that possible? With guards watching you breastfeed, watching your every move, watching you diaper, watching you comfort, right? How can we work to use this gold standard of care as a negotiation and an education tool for prison staff? Beyond all the things I've already said, it's really important to connect with community organizations that are serving this community. So the most obvious is the Elizabeth Fry Societies. Most provinces have other more local, like Wellness Within in Nova Scotia, or Coverdale Court Work also in Nova Scotia. So, you know, make sure that those organizations know about this person. Navigate how you're going to talk about a patient in a way that respects their privacy, but gets them the things they need, right? Privacy is to protect the patient. It's not to withhold them from getting access to services. Also, be connected to legal aid. You as a nurse can offer them clinical expertise. I write affidavits, a lot of clinical opinion letters explaining why, for sentencing purposes, it's not a good idea for this person to have a custodial sentence. They need to be with their baby. They need to be whatever, physically recovering. People who are in the court are not clinicians. They do not know this stuff, and you can help. And then, of course, I've already talked about this support. And then another thing that nurses can do is advocate for that doula, right? So we know that doulas in general, this non-clinical continuous support role, it reduces interventions, it increases patient satisfaction. But in the incarcerated population, we also see that it increases the likelihood of ever breastfeeding, because there's so many barriers to ever breastfeeding, not just the logistical ones, but the emotional ones, the trauma, right? Breastfeeding after you've been sexually assaulted is rough, right? When you're under surveillance, taking out a boob is really rough. And they're also doulas, just they can make you feel real powerful. And there's a lot to be said for the mental health impact of having agency. The doulas I work with, it's a big role. It's not just, you know, patting your back in a water bath. going to court. Being there when Child Protection Services does their assessments, because that's a big, scary part of all of this. Going to the prison, visiting, caring, gathering resources. Okay, so a little summary before we chat. I think I've established, I think prison is pretty bad for reproductive health, and we need to support efforts at a big scale so that people can avoid it or get out of it, decarcerate. People who are incarcerated have the same right to healthcare that everybody else does. There are barriers to abortion and contraception. There are challenges with pregnancies that are kept, challenges at every stage, prenatal, labor and birth, and postpartum, that nurses can help with, right? Most babies do not get to stay with their moms. And unfortunately, one of the most important takeaways from my talk is that you have to plan for the worst, because the worst is probably going to happen. What if the one person that you think can take care of the kid, what if they have an accident? What if the wound gets infected? What if, think of all the dimensions of worst case scenario and play it out. Because your future self will be grateful that you thought ahead and had contingency plans. And of course, every bit of love and care, that makes a huge difference. It really does. And it changes outcomes. So the point is to love. All right, there's my contact. There's my book. That's the end. Do you want to stop the recording, Megan, and we'll chat?